Alrighty, we are back here with eye injuries. We're going to go through um, pretty straightforward through a couple of the most common eye injuries, and then review some interventions. And main focus is on prevention, right? We don't want the patient to come in with any eye injuries. So how can we educate the patient on preventing them in the first place? And then our assessment. So we'll go on. Your objectives are the same. So I do have some pictures here for your introduction in your patho. Your first slide says, your first couple slides has overview, patho, and then a continued patho slide. So I kind of condensed those into one in order to show you the pictures here. So I'm going to explain each of them here. So any part of the eye can be affected by trauma. It really just depends. Any of the exposed parts are particularly vulnerable. The most common types of injuries are corneal abrasions, which are scratched eyes, is what they're usually called, lacerations to the eye, any type of foreign bodies, or penetrating eye injuries can happen to the eye. Chemical burns, which will happen after handling any chemicals, and usually the patient will rub their eyes afterwards. And then retinal detachment. So I'll go through each of those and kind of explain a little more. It really just depends on the nature of the injury of how it drives our interventions, but these injuries can occur anywhere, and we'll move on the next slide for that for the risk factors. There are several different types. So your slide says patho and etiology. So we have the closed globe injuries and open globe injuries, and we're going to kind of focus more on those open globe injuries. So lacerations, penetrating injuries, and then the foreign bodies. So there's full thickness wounds to the eye. So we'll focus more on those ones. I don't need you to know the difference between a lamellar laceration or whatnot, but I just wanted you to know the definitions of those, and anytime you might come across it in your nursing career. So we'll go back here to corneal abrasion. So let me get my pointer again. This is our healthy eye. And then a corneal abrasion can result from a disruption of the loss of kind of cells in the top layer of the cornea called the epithelium. So most commonly, some small particles can get stuck, and the patient will attempt to rub the eye so hard that it'll cause a scratch on the cornea. I actually, when I was doing this PowerPoint, I had a flashback. I remember that I actually had one when I was little that I scratched my eye so hard that I ended up having to go to the ED, and I got a patch on my eye. It really happens a lot with kids. So they end up rubbing their eyes so hard that they scratch it. So it can occur commonly around the eyelids or the cornea. And then it can become so scratched that it can break the cornea. So just be aware of that. It is kind of more self-limiting if it's a mild case. Foreign bodies. So we'll go on to this one right here. You can see this small area right here is a foreign body in the eye. That can be small dust particles, dirt, eyelashes, right? You can feel sometimes when you have an eyelash in your eye, it's kind of bothersome. But it can irritate the conjunctiva in the eye. And then it could kind of feel like something's stuck in there, and then it can blur the vision. So the pain can occur, but it's really not as common. Irrigation can be necessary to get that object out, and then the patient may need a cover on the eye so it becomes less irritated. Laceration here is on the top. So the laceration has to do with caused by, and it's right here. So it's a way bigger in-depth cut. This one is actually from a crab claw. I got this off the internet from Science Direct. It's a journal, a medical journal. So someone got scratched in the eye by a crab claw, and it ended up scratching the cornea. So the contents can prolapse through the laceration and cause irritation or infection in the eye. Chemical burns. I mentioned this just a little bit ago. So patients that are exposed to chemicals on more frequent basis, or if they're handling chemicals improperly without eyewear or gloves or whatnot, and they end up not washing their hands afterwards, or they get splashed in the eye, it can cause a burn of the cornea. So this is pretty emergent. They need to flush their eyes right away, and it can cause permanent damage if not addressed. Retinal detachment can happen when the retina is detached from the epithelium with age. As I said in my last PowerPoint with eye disorders, so with age we have less of that vitreous humor gel, which is kind of in the back here behind the cornea, holding it together. So over time, that gel shrinks or it thickens, causing it to pull away naturally. So any type of trauma can cause this detachment. And it can cause a tear. Also, rubbing your eyes can cause that to shrink over time and actually cause it to weaken. So we want to tell patients not to rub their eyes as much as they can, and children also to not rub their eyes. Okay, so I am going to go on to the next slide and we'll talk about causes of eye injuries. So we'll talk about causes of eye injuries, most commonly occupational hazards. So anything having to do with workplace chemical, lasers, irritants, construction sites can increase the risk of having eye trauma due to flying debris, chemical splashes, or blunt force. So proper eyewear is encouraged. Sports, direct contact sports, soccer, basketball, anything like tennis, anything that can cause injuries to the eyes. So it's important to wear goggles. Even doing yard work or carpentry or anything outside, you want to make sure that you're wearing proper eyewear. You could have it on hand, and make sure that it's available. Household accidents is actually very common with cleaning chemicals or cooking, oil splashes to the eyes, or you spray some chemicals and it ends up backsplashing, so it can result in a chemical burn to your eyes. Trauma from sharp objects, blunt force, and falls. So let's say a patient falls and they end up falling onto something and they hurt their eye. Age and physical vulnerability. So this has to do with children and older adults mainly because of poor coordination and poor vision, right? With older adults, our vision is impaired naturally because of the lack of muscle strength in the eye and that humor gel that's keeping it together. And then with children, it's lack of coordination and impulsiveness. So we need to be aware of that and educate both the parents and then the older adults, making sure that they have proper eyewear and they have what they need in order to see. Now we'll go on to prevention. I have some lovely pictures here of how we can prevent eye injuries in the first place. So as in your slide, it says that using that protective eyewear can prevent injuries up to 90%. So it's really important that we educate the patients in proper eyewear. So if they're working in a specific occupational field, they should be wearing something like this. And like I said in my last PowerPoint, even us as nurses, we would be wearing something like this to protect our eyes. OSHA, like I was talking about, Occupational Safety and Health Administration, they are the ones that regulate who should be wearing what type of eyewear. So if the patient is not aware of what they should be wearing, then some type of education on this administration can be necessary, and you can print them out some information on that. Eyewear for at-home use. You can just keep it in your garage or keep it in your kitchen and let the patient know that when they're handling chemicals or doing yard work, they can just grab these goggles to make sure they're protecting their eyes. But it should be labeled the ANSI Z87 to make sure that it's durable. Anytime you're out in the sun and anytime you're doing any extracurricular activities like sports, as we see here in the picture, for skiing or sun sports, we want to make sure that we're having proper eyewear and goggles that are necessary for those sports to prevent any injuries. Okay, going on to clinical manifestations. So several tables are in your PowerPoint, and I just want to point out that they are comparing and contrasting the most common eye injuries. So first one we have here are corneal abrasion and retinal detachment. So we talked a little bit about that earlier. So the corneal abrasion has to do with the scratches on the eyes, right? And I'm going to go back here in a bit, if I can, to show you that corneal abrasion. So you can take a look, right? It's that small scratch on the top of the eye, usually due to excessive scratching or some type of distinct trauma. A lot of the times too, it's due to contact lens misuse or accidental scratches. So like I said, so the patient will commonly report sharp, intense pain that worsens with blinking or eye movement. So they try to blink and try to get out the scratch, but it's not going to leave because it's on the cornea. They can have some redness and blurred vision, but the symptoms are going to come on suddenly. Okay. Let's see here. They don't really have floaters usually. Flashes of light are rare. It usually resolves and is self-limiting within 72 hours. So it's not really vision threatening. It's only urgent if they're having complete vision loss. In contrast to that, retinal detachment is typically painless, but they need to come in because they will all of a sudden see some sudden onset of dark floaters. Some flashes of light can be seen and also a shadow. It requires surgical intervention in order to reattach the retina. Okay. So again, some key differences of those are the corneal abrasion is clinical manifestations are sharp, intense pain that worsens with blinking or eye movement, presents suddenly and resolves within 24 to 72 hours. Retinal detachment is painless, sudden onset of floaters, flashes of light, and a curtain-like shadow. Okay. Retinal detachment is urgent and needs surgical intervention. Okay. So think about some questions you would ask this patient based on their cues they're giving you. Okay. Before we get into our assessment. Trauma. So for eye trauma, that's a little different, right? It has something to do with maybe that flew into the eye, or trauma that has to do with flying objects. So there's several different kinds. I do want you to focus more because you have several boxes here, right? Penetrating, blunt, and ocular burns. I want you to focus more on the penetrating trauma. And also the ocular burns. So with penetrating trauma, it is very severe, sharp pain. They're gonna have some type of laceration, and it's emergent. So they're gonna need to come in as soon as possible. So again, what kind of question would we ask? Okay. With the ocular burn, that's going to hurt. So it's going to be pretty painful for that patient. It's going to be a burning pain. They may not be able to see as well. There's going to be some redness because it's irritated. And then they're going to feel like they have something stuck in their eye. Okay. This is also emergent because it needs immediate irrigation. And we need to get the chemicals out of the eye. Okay. So how are we going to assess the patient? Okay, so what questions would we ask the patient? So what time did this happen? What was happening when the trauma occurred? What flew into their eye, or what were they doing at the time of the injury? What were the circumstances surrounding it? Did something help or hurt it? Okay. Did this happen all of a sudden, or did it happen gradually? Did they wear contact lenses or glasses? Were they wearing any protective eyewear when it happened? Do they feel like there's something stuck in their eye? Is there any edema, redness, discharge? Have they had this happen before? Doing a vision assessment will be essential for this patient. So what cranial nerves are we going to test? I did give you a hint here, but I need you to know this. Definitely need to know. So your cranial nerves, right, are 2, 3, 4, and 6. You have 2 for optic, 3 for oculomotor, which is measuring your perla, 4 for trochlear. So this is your eye movement down and lateral. So you have them follow the pen light down and sideways. And then 6 is your abducens. They're moving it laterally and side to side. Okay? So I do need you to review that and also review your perla to make sure we're assessing that of the patient. Are their pupils equal? If they have a foreign object in one eye but not the other, so how are their pupils looking? They're probably going to be unequal. Are they round in shape? Are they reactive to light? How about accommodation? If you have them follow your finger or your pen light, are they able to accommodate? Okay. How is their eye movement? Okay. So what are our priority diagnosis or problems? So this slide is actually down a little bit in your copy, but I moved it up towards mine on this one. So our priority diagnosis would be someone that might have an eye injury is probably going to be in pain. So acute pain may be one, impaired sensory perception, anxiety, impaired tissue integrity, inadequate tissue perfusion, and of course, reduced vision. They're not going to be able to see as well as they usually do. So we need to address those issues, right? They're going to need pain medication. We need to get the foreign object out. We're not going to get it ourselves, but we need to make sure the provider knows. Okay. We need to ensure adequate tissue perfusion and sensory perception. We need to make sure we're supporting them and calming their nerves. Okay. So we're going to go on to some solutions and actions. Okay. So we will collaborate with the team, usually an ophthalmologist, primary care provider. We're going to figure out what we need to do, right? So some diagnostic tests. We already have our cues. The patient has an eye injury. We have a priority problem, so we need to resolve it, right? So they might order some visual acuity tests, slit lamp like we spoke about in eye disorder to measure that corneal defect, some CT scans or MRI to view extent of the trauma, or some facial x-rays, okay, or a fluorescent stain. So they'll inject the dye to figure out the flow of blood in the cornea, okay? So depending on the extent of injury, those medical interventions can vary completely widely, okay? Some interventions based on the extent of injury can include for corneal abrasions, they might have surgery. If it's severe enough. So if the corneal abrasion has completely scratched the cornea and damaged it, then they would need surgery. If it's mild enough, it's usually self-limiting. For severe chemical burns, they might do debridement, tissue grafting, or a corneal transplant. If you guys have ever heard of that, they actually do corneal transplant from cadavers. Penetrating wounds usually require ophthalmic surgery. Blunt trauma, again, depends on the extent or type of injury. We never remove any foreign bodies or anything, any kind of trauma from the eye before the provider sees the patient. Okay. Retinal detachment, they're going to need surgery for, so there's several different types. Laser photocoagulation, it uses a laser beam to seal or destroy the abnormal blood vessels. Cryotherapy involves intense cold to the outer eye to freeze the retinal tears and promote scar formation. Sclerobuckling is a surgical technique where a silicone band is placed around the eye to push the wall of the eye against the detached retina, so it'll reattach on its own. Pneumatic retinopexy is a minimally invasive procedure where a gas bubble is actually injected into the eye to press the retina back into place. So any of these procedures though, right, somebody's going to need to take that patient home because they're not going to be able to see very well afterwards. Okay. But retinal detachment is a medical emergency and they're going to need surgery for it. Okay. Some pharmacological therapy. For corneal abrasions, they might have antibiotics just to prevent infection, right? If there's a scratch, that is an open area for bacteria to get into. So we don't want that patient to have an infection. Okay, so they may need to get some creams or oral antibiotics. Burns, chemical burns definitely need pain medication because that is very painful. Steroids to decrease inflammation. For any penetrating or perforating injuries, they're going to need pain medication also and sedation as well as antiemetics because of the nausea. After the surgical repair of retina detachment, they're going to need some steroids to reduce inflammation because their eyes are going to be very puffy and edematous. So they're going to want to reduce that inflammation. some actions that we're going to take for this patient in order to intervene and provide nursing interventions. We want to reduce the risk of impaired vision and have a higher quality of life, right? So we want to make sure that we notify the healthcare provider immediately if there's any changes in vision. We want to make sure that we reassure the patient that most of these surgeries, especially for the retinal detachment, are successful, and they're just going to need to make sure that they have proper home care so they avoid any bending, lifting, or straining, so they don't detach it again. We want to make sure that the patient is applying those eye drops or ointment as prescribed, promoting rest, stabilizing the eye. If they have a patch that they need to put on the eye to prevent any further irritation, they're going to have to wear that as the provider prescribes. Following up with treatment and coming to the follow-up provider's appointments. For lacerations, they might have antibiotics to prevent infections also. They might treat them in the ED and suture. Again, with penetrating wounds or objects in the eye, never remove the object. The provider will assess it first and evaluate it. They may need surgery to remove it, but they're going to get antibiotics before the surgery as well as a tetanus shot. For mild foreign bodies, like small ones, that's not penetrating, they may just flush with saline. So education is essential, right? So proper eyewear, avoid rubbing the eyes, seek care as soon as possible, wash your hands after handling chemicals, and making sure that that patient has proper screening and making sure that they have interventions in place to prevent the injuries. All right, so our evaluation. We want to make sure that we evaluate our outcomes. So did they have vision return after surgery? And then we prevented complications from happening again. We're making sure that their pain is managed. And then we don't want them to have any complications of infection after surgery, or if it's a self-limiting injury, we want to make sure we don't have any infections at all. So making sure they finish out their antibiotics, and then they're following up with their healthcare provider. Lifespan considerations. So we want to make sure that we are letting those parents and caregivers know that children are more vulnerable getting eye injuries. So, right, children are always playing contact sports or getting in each other's space. So we want to make sure we tell them to avoid throwing balls at each other's faces because of the risk of eye injury, throwing sticks at each other, everything below the waist, preferably. That we put all household chemicals up high where children can't reach them. And then we're making sure that if the child has any edema or any type of redness, that the caregiver brings them in to the provider's office, or any discharge of the eyes. Another sign of eye injuries that I just want to mention that you would be a mandatory reporter for would be periorbital ecchymosis. So bruising around the eyes, right? So that might suggest abuse of the child. So make sure that you're assessing, right, your full head to toe as your baseline. So we want to make sure that we're not missing anything. Older adults is your other vulnerable population. So hospitalizations for this have been on the rise because of falls, right? Patients think they can as they get older, your vision becomes more impaired, as I mentioned. So outside, they may not be wearing the proper eyewear and then fall, and then a stick may get in their eye, or they may fall on a rock or something, right? So making sure that they're wearing proper footwear and eyewear. They're getting used, they have a decreased sense of balance. They may have diagnosed with cataracts or this or that, and there's decreased cognition anyhow. So, teaching those methods about prevention of falls and safety in the house. So just make sure you educate on that. So if I could emphasize anything on this whole thing, right, would be prevention and then your assessment and making sure that you are addressing the urgency of retinal detachment and making sure that they know to come in as soon as possible. And then also knowing about OSHA. OSHA is your workplace safety and health administration, and then your patient should know about that with occupational hazards. Okay, so I don't need you to memorize all those clinical manifestations, but know your most significant ones, right? So for your corneal abrasion and retinal detachment, penetrating trauma, and ocular burns, and then your more significant lifespan considerations. Okay? If you have any questions, just let me know. I'm going to move on here to peripheral neuropathy.